Hello, can you guys hear me? Yes. All right. So I'm going to move this over here. So I am a pain management physician, and I practice in South Florida. And today I am talking about ketamine-assisted therapy for chronic pain. And over the past decade, I've had a fascination with how acute pain turns into chronic pain. And we have learned a lot from neuroscience, thank you, about how chronic pain develops. And what I've seen is that we need to use a mind-body approach in order to treat the entire person. And so my training was in interventional pain management. However, I take a much more integrative approach to treating chronic pain. We have 50 million Americans, which is 20% of the United States, in chronic pain. We have an opioid epidemic. People are choosing to numb themselves as opposed to dealing with their pain and sitting in the discomfort. And what I want to do is encourage everyone to realize that the opposite of pain is love and pleasure, and how can we integrate more love and pleasure into people's lives. So I'm going to teach you a little bit about how chronic pain develops. The brain and the body work, and they're always in communication. And so pain is actually a sensory or an emotional experience, and there doesn't have to be any physical tissue damage in the body for someone to have pain, which basically means that pain can change and be reprocessed. And so what's happening is people are under chronic stress, and it's creating an environment within their body and their nervous system that amplifies the pain signal. And the other thing about pain is the context matters. For example, I could have chronic neck pain and be giving this talk today, and perhaps my neck pain got worse because I'm stressed. Or someone can have a sexual encounter with someone, and they could have consent to doing some type of activity that may cause them harm in another situation. So the context is very important. Now, we used to treat pain from a biomedical standpoint, looking specifically at neurotransmitters and receptors in the body. And that was really, I think, from the chemical imbalance theory, the fact that we thought depression was an imbalance of serotonin, and Big Pharma taught us that we should take opioids to get ahead of our pain so that we don't actually feel our feelings. And now we're taking more of a biopsychosocial approach. So there's different types of pain. And so I want to talk about specifically which type of pain we can use with ketamine-assisted therapy. There's nociceptive pain, which means that it is secondary to a disease process. Someone has rheumatoid arthritis, ulcerative colitis. Sometimes we can have benefit from this type of pain, but that's generally not what we're using ketamine for. Then there's neuropathic pain. That would be pain in a specific nerve root. You have trigeminal neuralgia, postherpetic neuralgia, sciatica, or you have a central neuropathic pain like a spinal cord injury or a stroke. Then there's nociplastic and neuroplastic pain. Neuroplastic in the word means that there is change within the nervous system. So all of these conditions like fibromyalgia, chronic fatigue, chronic migraines, pelvic pain, IBS, endometriosis, and even things like anxiety, depression, PTSD are technically nociplastic pain. They're primary pain. There is no reason for the pain. It is called neuroplastic. And because it's neuroplastic, it means that it was created by neuroplasticity, which means we can reverse it and reprocess it. So what's happening in most of the specialties, especially with chronic pain, is we are trying to figure out and predict who will develop chronic pain. And so by taking a more personalized, precision type of process, we can actually identify, for example, someone who has adverse childhood events, someone who has multiple traumas, they're more likely to develop chronic pain. If we're going to do surgery on someone who's on high levels of opioids, it's going to be difficult for us to control their pain after. If somebody has had different type of psychosocial issues in their life, this may contribute, as well as their genetics, what's going on functionally in their brain as well. So chronic pain develops, by definition, you have to have it for at least 3 months, which means the natural body didn't heal. The normal time for the tissues to heal has not occurred. So chronic pain is a process that happens in the body that then is actually spread into the central nervous system, which is our spine and our brain. And Descartes was the first to really understand how pain works. You sprain your ankle, you have a lot of inflammatory mediators that come and try to heal the process. It gets red, it gets swollen, the skin and the tissues around it get sensitized. If that pain stays for a long period of time, it spreads up into the peripheral nerve, into the spine. Then there's centralization of the inflammatory mediators, and then it goes up to the brain for us to think about the pain, feel the pain, perceive the pain, and then for our brain to tell us to do something about the pain. The best example of understanding why pain does not just live in the body is from phantom limb pain. So someone has an amputation, they sense that they have pain in a limb that doesn't exist. The brain has made a map of the body, and now your brain is telling you that you still have pain in a part of the body that doesn't even exist. So what this person is doing here is looking in a mirror at his good limb to represent the limb that's no longer there, and he's either massaging it or putting on medication to try to trick his brain into thinking that he's healing the other limb. There's many places along the path for where pain is processed that we can use different medication. Local anesthetics like lidocaine, anti-inflammatories, gabapentin, opioids, ketamine, from the peripheral nerve in the body into the dorsal horn of the spine up to the brain. So that's why multiple meds are used in chronic pain, because we're trying to decrease 10 to 15% from this point and 10 to 50%, thinking that we can actually control some of their pain or help them manage their pain. But what's actually really important is the perception of pain and what's happening in the brain when someone's in a chronic pain state. This is an example of a construction worker that fell at a construction site on a screw that went through his boot. He was screaming, crying all the way to the emergency room in the ambulance. And when they got to the emergency room, they took his boot off and they realized that the screw hadn't even pierced his skin. And so the fact that he had so much fear about what had just happened, and this word about catastrophizing, which means that you're always thinking things are going to be worse than they are, can create this perception, and he caused this experience to be painful even though there was no damage to his actual tissue. So the triple network model is something that is used a lot in neurology and psychiatry, but it actually now can also be represented with chronic pain. What this really shows is that we have different networks in our brain. A lot of us know about the default mode network. That's the story of who we are. The default mode in chronic pain patients is hyper-connected, which means that they are thinking about their pain, they're ruminating about their pain becomes embodied, they are their pain. So the default mode is hyperactive. Salience network has to do with the amount of suffering this pain is causing them. And then the central executive is the fact that they are not doing their certain functions and activities of daily living and goals. So in chronic pain states, these networks become hyper-connected within themselves. With classic psychedelics, less so with ketamine, there is this disruption where within the networks, they're less focused inside the network, and there's more of a global connectivity throughout the brain. So this is actually newer information with psychedelics, but the fact that these networks disintegrate and start to communicate on a functional level with each other allows for this reset within the brain. So what I really want to focus on is how chronic stress and trauma and things that we are not aware of physically from the body are creating this amplification of signals into the brain. And people are living in a state of chronic pain, mainly because of chronic stress. So the fire alarm is basically going off, and that's the problem with the nervous system. People are in this state where they're thinking that there is danger or there is threat to them, but there is actually no danger. And I say that often to the patients, like, there is no lion in front of you, there is no fire in front of you, but yet they feel like their body is in a state of threat. So all of these things relate to why people get something called central sensitization, which means that the nervous system is hypersensitive. It's because we're not able to take care of their pain with their natural opioid system. They have this disruption within the default mode, activated glia, which creates neuroinflammation, and this increased activation of pain receptors. Also, there are different risk factors for central sensitization besides genetics. There's also people who have anxiety, depression, catastrophizing, and as well personality and traits and characteristics of someone. For example, someone who has chronic pain, who has that type A conscientious personality, they want to know what is wrong with my body. They're going to go to every specialist until someone finds out what's actually wrong with their body, and there may not be anything wrong, which is why someone who has fibromyalgia and chronic migraines and endometriosis sees all these different specialists, yet it's actually all from a hypersensitive nervous system. And the hypersensitive nervous system has to do with an excess of glutamate, which is an excitatory neurotransmitter. So glutamate is ingraining these neural pathways, creating an activation of these receptors called NMDA, and the NMDA receptor is the hallmark of neuroplasticity. It is central to creating new neural pathways. So how does ketamine work for chronic pain? Well, ketamine is a dissociative anesthetic, so in the definition of that word, it's an anesthetic. It gives people pain relief. It allows them to have space so that they can reprocess what's going on. It gives them this unique access to different parts of themselves that they may not have had when they were in their conscious mind. And this time out, we call it, the space that they're creating while in a dissociative state, allows them to think and feel differently, perhaps feel love or feel peace that they haven't felt before. And what ketamine's actually doing is blocking the NMDA receptor. So if you're following, you would say, why would you want to block the receptor that creates neuroplasticity? So it actually blocks that receptor on GABA neurons, and GABA are inhibitory neurons. So it creates a glutamate surge. So you give someone ketamine, they have 2 to 3 days of this neuroplastic window. That's why the therapy is so important to occur in a short period of time after, because you want to reinforce the fact that they need to make change, and you're given this catalyst to help you make change. So they need support, and they need to feel safe. And how can we make them feel safe is really very important. This is an example of someone who has complex regional pain syndrome, which is a pain syndrome that is a hypersympathetic nervous system situation. You can see here her foot is very red. That's how her foot always is. This is 3 days after doing ketamine. So not only does it control the pain, but it's showing how it decreases what's happening in her sympathetic nervous system. The other thing to note is that who was she before she developed complex regional pain syndrome? The point is there's always a story. The stories live in our tissues, in our subconscious, and so we can help people access this. Ketamine disrupts the default mode, and there's a lot of neuroscience behind this. Now, specifically getting to what the guidelines are for pain. This came out in 2019, and it showed that ketamine is great for pain from complex regional pain syndrome, but only for a short period of time. It has a very short half-life, and therefore ketamine requires multiple sessions. It can help people who have chronic pain with an associated depression, anxiety, or PTSD, but there's weak evidence for just chronic pain by itself. And sometimes we use it in patients who are opioid tolerant so that we don't have to increase their opioids. Now, in terms of protocols, so when I was trained by the Ketamine Training Center, there was a psychiatrist there named Gita Vade, and she used the phrase the experience of the patient. When you're sitting in a room with the patient, what is the experience of the patient? And I think that is really the most important thing you can take away from this talk, is that we need to be able to understand what's actually happening with that person in order to put them back together. It's not just where is your pain in the body, it's how did you develop this pain, what are your coping mechanisms, who is going to be there to support you. So some people do 5 days in a row, long IV infusions with other meds and benzos, and they take away the amazing psychological insight. I personally would generally do twice a week for 3 weeks, then with maintenance required after that, depending on the person. I also do intramuscular, not just IV. It depends. Every session may be different because we're treating the person. We're not treating their body. This study came out, which really helped me to feel better about the way that I treat chronic pain with ketamine. Because when I was trained 12 years ago, I was trained very different. This study actually showed that people who have more depression with chronic pain when given ketamine have more pain relief, because depression is one of the main mediators for treating chronic pain with ketamine. Which means if you have someone who has chronic pain and depression, they're more likely to get better than someone who just has chronic pain. And that's because we need to use a biopsychosocial model. So that's looking at the entire person, because our thoughts, our perceptions, emotions, and context, plus the sensory inputs, all amplify or reduce pain, and this defines that person's experience of pain. So some of the things that I do, we try to increase resilience to pain and the capacity to sit in the discomfort and not to numb yourself or to use another medicine as a substitute. And this was a study that I had done that we published in Frontiers in Pain, and really what it was showing was that higher doses of ketamine with therapy is the way to treat chronic pain, as opposed to not having therapy. And so I think a lot of pain doctors are not including preparation, therapy, and integration, and therefore they're not having long-lasting changes with their ketamine for chronic pain. Pain reprocessing therapy, my team is trained in pain reprocessing therapy, and what this is it's a form of therapy to help retrain the brain accurately to understand that that fire alarm that's going off is actually, it needs to be recalibrated. And pain reprocessing goes along with ketamine. So after a ketamine session, someone may not have any pain in their body, and what we're trying to do is explain to them this is possible, and we do that by something called somatic tracking. They track where the pain is in their body, they're mindful of that pain, we're constantly reappraising the fact that they're safe, there's no threat, there's no structural damage, there's no anatomical peripheral problem that we need to take care of, and then we can reprocess their pain. And a lot of this has to do with the fact that fear and uncertainty create a hypersensitive nervous system, creating the sensation of pain. So when you really understand that pain is just a sensation or emotional experience without tissue damage in the body, then, and we educate the person to understand that, then we can really help to reprocess the pain. So we do something called a pacing protocol. Pacing protocol means we understand what makes someone's pain worse, what makes someone's pain better. That's like a pain recipe for success or disaster, as well as in terms of the pain volume, what will turn your pain up and what will make it less. For example, sleep, better sleep habits, or social connection, or doing certain types of movement. And we give them a protocol. So we start off with 10 minutes of exercise every day, or 3 times a week, let's say. And then what we do is we build up consistently this protocol, and that's why it's called pacing, because the importance is the consistency of the treatment plan. And that's one of the biggest issues by the fact that ketamine's not covered by insurance, because the person can only come for a certain amount of sessions and they feel great for a little while, and we're getting them engaged, and then they're a little bit more open to making these changes, and then insurance doesn't cover it, and then we're really trying to help them. And the goal here is to try to figure out how can we have insurance cover ketamine-assisted therapy? And I think that that's only to show the longitudinal evidence, and that only happens really with therapy in a very safe container. So the reason why pain reprocessing works, this was a study done called the Boulder Back Pain Study. They took 100 people with chronic back pain. 50 of them got pain management as we would usually do it, and 50 of them got pain reprocessing therapy. And the pain reprocessing therapy, 98% of the patients improved, and 66% of them were nearly pain-free at 1 year, which means that we could just take pain reprocessing therapy and use it for chronic pain as a first line before even introducing a medication. So this is a picture of some of the wonderful people in my team, and I have a lot of my team members here, and we are a team, and the patients understand that we are a team, and we all collaborate to help this person. Now, this man is a veteran who has PTSD and neck pain. Now, if he sees me for neck pain, but he sees a psychiatrist for PTSD, are we going to treat him differently? Are we going to give him different doses of ketamine or try to have a different protocol? The point is, this is a person, and we're not treating specific conditions. We're literally treating the person. We want to know how he developed to have chronic pain, who he was before, who's in his environment who's going to support him. And just to end, this was a study done at Stanford that shows that love blunts the pain response and increases the threshold for pain. And the reason why I'm showing this picture is because this is my grandma, and she's a little lady because she had multiple compression fractures and had severe arthritis. And I can guarantee you that every time I was with her, she was full of love and had a huge smile on her face. Bless you. And the point is that if we can help people feel love, if we can medicate people less so that they are able to use their natural systems to have pleasure in their life, then they're not as focused on their pain. So it is important for us to understand pain, and we can understand it better because we have neuroscience, we have functional MRIs, we're looking more at the brain than the body. But first we need to make the person feel safe. And when we're giving them ketamine, they must feel safe so that they could surrender, so that we can give them access to parts of them that they're not really comfortable sharing with us. Perhaps someone has shame that is now living in their body, creating this sense of pain. So yes, there are biomarkers that can help predict who's going to develop chronic pain, but in general, neuroplasticity created this chronic pain. Neuroplasticity can reverse the chronic pain. And so what we're doing is looking at the whole person. And I do believe that there's many other things that are going to come about with lidocaine infusions, or people add magnesium to it. And there's all these wonderful things that can help reset the brain, treat the pain. I do think pain reprocessing therapy is really an amazing therapy, like internal family systems, for example, for mental health. That's what I use for pain. And I'll end by saying that ketamine can be addictive. And so I am talking about harm reduction. Someone who is in chronic pain, who's severely suffering, who perhaps is addicted to opioids, who needs another option, the first thing they need is hope. They need to understand that there are options to get them out of this state, and they need to understand how they developed to have chronic pain, and then they need support and a safe environment for them to be able to be who they need to be to live their life fully. So thank you very much. I think that's it.